Hello, everyone, and welcome to our third episode of Fireside Conversations. And today we have Dr. Sudeepthi Prasad with us. It's wonderful to have you here, Dr. Prasad. Welcome.
Hi, very nice. And with your friend. So looking forward to it.
Yes. So we've been friends for a long time, as well as obviously, in a professional capacity here today. So I'm really looking forward to this conversation with you. I'll just give a brief introduction, everyone, to Dr. Prasad. She is MD FACOG, a senior consultant in obstetrics and gynecology in California, in the States. She has a special interest in laparoscopic surgeries in fertility and menopause. She's also a certified Ayurvedic lifestyle and yoga instructor. So she's got a few, she wears a few hats. And what really fascinates her is the integration of Ayurvedic lifestyle with scientific modern medicine. And it's wonderful to have that marriage of sorts. So, Sudeepti, it's wonderful to have you here today. Welcome. And we look forward to hearing from you about your specialty, really, which is about women. And I was hoping we could get a different perspective, really, on women, perhaps link it to some of the presentations you have seen and see how one needs to be aware of self-care and emotional well-being as a woman.
Good morning. Thank you for being here. The goal today is to enhance women's health awareness when they go through all stages of their life, starting from puberty through their reproductive age when they have their menstrual cycles, perinatally, postnatally, during their pregnancy, and when they go through the transition, which is menopause. Let's first take puberty. So when the girls first have their cycles, I have a 12-year-old, I'm sure some of you have girls. So it's very important for the parents, the mom especially, to talk to their daughters about the changes their bodies go through, even before they actually have a period, when the body is going through the changes. Just so they know how to deal with the different symptoms they go through. Let's talk a little bit about the menstrual cycle. The average menstrual cycle is about like 28 days. The first half is about 14 days, which is called the follicular phase, where your body picks the best egg, and then there's egg release, which is ovulation, and then there's a luteal phase, which is the second half of the cycle. So what happens is when the egg gets fertilized, and that goes on to become pregnancy, and when the egg does not get fertilized, then you'll have a period. That's about what our women's body does all through their lives, having their period until they get into menopause or pregnancy. So the period right before they have their menstrual cycle, which is about 5 to 7 days, sometimes up to 2 weeks, but mostly about 5 to 7 days, they start noticing pelvic cramping, sometimes headaches, irritability. The most common symptom they complain of is usually pelvic pain and cramping. It's mild, lasts for a day or two, and then usually goes away. And that's about the normal part of it. But if the symptoms are really severe, if there's excessive cramping, if they miss school, if they do not want to go to PE, that's something where you need to pay attention, and then make sure they see the pediatrician, who will in turn refer them to the gynecologist so they can have a little bit more conversation about it. Yes, sometimes you could just do over-the-counter pain medications for the first day if they're really concerned. But if it's really severe on a scale of 1 to 10, if it is 9 or 10, then they do need to get some medical help. The other thing is mood symptoms. Sometimes it's just irritability. Sometimes they do not want to talk to anyone. They could pick a fight with the parents sometimes. So it could be different things. If it is ever affecting their studies, if it's ever affecting any other part of their life, so pay attention to that. Most of the symptoms are milder. They usually go away. Most girls do great. Sometimes the symptoms are worse. On a scale of 1 to 10, it's 10. So those are symptoms you need to pay attention to. So I have a list of the symptoms I made, just wanted to make sure I cover everything. So usually, yeah, mood symptoms, headaches, poor sleep, acne, oily skin, breast tenderness, food cravings, bloating, menstrual cramps we just talked about. They could also have constipation, diarrhea, anxiety, irritability. So they could have any of those. So PMS, there is a concept, there is a disorder called PMS, which is premenstrual symptoms, which 20% of women have it. That's when they need some help with it. And there's also something called PMDD, which is premenstrual dysphoric disorder, where the mood symptoms are really worse. They could have fatigue, back pain, really bad abdominal pain. Mood symptoms are very, very enhanced in PMDD. So there are treatments available for this. The most common one, which is recommended really in low dose birth control pills, or the hormone pills. Contrary to the belief that they're going to somehow harm them in some way, not true. It does not cause breast cancer. There are studies which have showed that. And it in fact prevents ovarian cancer if you're on them for about 10 years. And if they really need to be on that, it's okay for them to start the medication. See how they do the next few cycles. If it's really helping them, then just leave them on it, but just always pick the lowest dose and then talk to your gynecologist about it. And let's see. I think I covered most of the common points we see. And women go through this over and over again. With every decade they age, like in the 30s, their 40s, the periods are a little bit different. The way they feel, their symptoms are different. So that's also something to pay attention to. So let's talk a little bit about pregnancy. So when women go through the pregnancy and all the symptoms we talked about the PMS, all the breast tenderness, the bloating, and everything gets worse. And the hormones, which are normally, say, estrogen, which is the levels are about 60, in pregnancy, they go through like 10,000s, like both estrogen and progesterone. So the symptoms, what you notice during pregnancy as far as mood symptoms and being really emotional about things, is really enhanced during pregnancy. And first trimester is a big change for women when they're going through all the symptoms. They're excessively tired and they feel sleepy all day long, all because of the hormones. And they're not really hungry during the first trimester as much. Most women think that they would have excessive cravings as soon as they get pregnant. That's not so. In first trimester, not so much. Nausea, vomiting sets in. And they sometimes are not able to concentrate on their normal job, what they do, just because they're just sleepy all day long. So those are the first trimester changes. Second trimester changes relatively, or they feel better, the mood symptoms get better. So usually the second trimester is a good time in pregnancy. And then third trimester, again, most of the symptoms worsen because the baby is growing bigger, baby almost triples the birth weight in the third trimester. So they'll notice all the symptoms, all the low back pain, the groin pain, the pelvic pressure. So all the symptoms are really enhanced. In addition, the mood symptoms with it. At 28 weeks is when they are screened for depression, and we use something called a Edinburgh postpartum depression scale. So depending on the score, usually if it's about 14 and above, then they are at really increased risk for also postpartum depression. So we pay more attention to them, and most pregnant patients are skeptical about starting any antidepressants during pregnancy. So that is a conversation to be had. They're seen multiple times all through their pregnancy, almost every month until about 30 weeks, every 2 weeks for another month and a half, and then every week for about a month before the due date. So that's a lot of opportunity to have the discussion with your obstetrician to see what works for you, and if you need to see a therapist for some reason, cognitive behavioral therapy really works. Talking to a therapist if you're having any negative thoughts, and then work on them. So that really helps. Even without any medication, seeing a therapist really helps. So that's something you want to talk to your OB if you notice any of that. And also, like when you're in the hospital, the postpartum depression scale is administered again before your discharge, and then when you see your OB again for your postpartum visit. And it's really important to get support of the family too with all this, because they are the ones who are with you, and then usually women with good family support do relatively well than women who do not. So and the family is the one who will notice any changes or anything untoward during the postpartum depression. So women, there's something called postpartum blues, like right after the baby is born, within the hormones really drop. So, and then they drop gradually over the next 6 weeks, but the first 2 weeks is really, really important. That's when about 80% of women go through postpartum blues, where there's like frequent crying episodes, and it's very normal. They do not need medication, but just enough support at that point. And there's two other components to it, postpartum depression. When this postpartum blues, the mood symptoms, and of course, there are a lot of confounding factors, because you're up every 2 hours, you're caring for this new life, you're breastfeeding, there's no sleep whatsoever, and you're sleeping, your dietary pattern and your sleep patterns and everything have changed. So they're trying to cope up with a whole lot at this point. And when these crying episodes are persistent, negative thoughts are persistent, then that's something where you need to talk to your OB about it. And about 10 to 20% of women go through postpartum depression. And yes, it's a real thing, and it's very important that family knows about it. And also there's something called postpartum psychosis, which 1 in 500 to 1 in 1,000 women go through it. It's not very common, but that's something to be screened for, because if there is, you do not want to ever miss it, because there are thoughts of hurting yourself, and there's homicidal ideation, which is thoughts of hurting the baby. There, I wanted to share you an anecdote, which is very, very sad. One of our, not our patient, but one of my colleague's patient who was in the community. So she just had a baby. She was about like maybe 3 to 4 weeks postpartum, and she had one other older kid, and all this happened in a matter of like 30 minutes. Obviously 30 minutes when the things happened, but obviously it's been brewing for the last 4 weeks. And maybe through the pregnancy. The husband and the older kid just went out to get something from the store, and then when they got back, the whole house was on fire. So she basically lit the house on fire with the baby and herself, and it's really sad, and both of them passed. That's something it could have been totally avoided, knowing that there is postpartum depression, there is postpartum psychosis. It is a component. It's something you need to really pay attention to. So if you do notice anything at all, anyone, your wife, your sisters, if in your family, if you notice it, or if it's you, I mean, just know that you need to get attention. The next thing I want to talk about is menopause. All women go through it, whether we like it or not. The average age is 51, but you could go through with it anytime after 40, after 45. Some women may last until 55. And the most common symptoms we notice are hot flashes, vaginal dryness, and irregular bleeding. Hot flashes are something where you'll feel really hot, like the upper part of the body, anxiety, palpitations, and then when those go away, you completely sweat profusely. That's because the estrogen, which is the temperature controlling center in your brain, in your hypothalamus, those levels are decreasing, and they don't go down just like turning off a switch. They go down very gradually, unless it's a surgical menopause. You remove the ovaries and it's going to hit you within the next week. And of course, if you remove surgically the ovaries, then they need to be on some kind of hormone replacement, which we'll talk in a bit after we talk about the menopausal symptoms. So hot flashes, if you do notice those, definitely talk to your OB about it. Sometimes it could be 10 times a day, so that really disrupts your life. And they could happen at night. You could wake up 3 to 5 times a night, and then your sleep is almost non-existent. and the vaginal dryness. So both estrogen and progesterone hormones really decrease. So you'll have pain during intercourse. So there are medications, like topical medications, like an estrogen cream, your gynecologist could prescribe to help with that. And then irregular bleeding. So irregular bleeding, it could start really early, like 2 to 5 years, 8 years, right before your menopause, which is called the perimenopausal period. And if you do notice it, as long as you do not have like super heavy bleeding, then if the bleeding decreases a little bit, that's okay. You're not going to get anemic. But if you have heavy bleeding, irregular bleeding, like if you start bleeding like every week, every 2 weeks, and the bleeding is heavier, then you do need to see your gynecologist. And also they would do something called an endometrial biopsy, which is to rule out any abnormal cells or cancer cells, because as we get older, we are at increased risk for cancers. So definitely that's something you need to talk to a gynecologist about it. An endometrial biopsy is something which they could do outpatient in the office, and takes like 5 minutes to do it, and you could be pre-medicated for it, and then they could do it in the office, so you don't have to be under anesthesia. And most women do tolerate it very well. The other symptoms are sleep, irritability, difficulty concentrating, joint pains, and loss of libido, not wanting to have sex at all, memory loss. After 40, we notice some kind of like gaps in short-term memory sometimes, but that's okay. That's very normal. And that's when you start keeping lists and make sure that you've done everything on your list. But the short-term memory problems usually get worse with menopause. And then sometimes headaches usually comes with the vasomotor symptoms, which are the hot flashes. There are treatments available for this. One of them is hormone replacement therapy. I'm not talking about oral, like oral medication. There's a patch, there's like creams available you could use. So that way the side effects are not something which we would expect from oral medications. All the breast cancer, colon cancer, heart disease, stroke, those are all with like oral medications. But we are really bypassing the liver with using topical medications, which is either on the skin, or you could use a patch. You could use topical, like a vaginal medication, depending on what symptoms you have. Every woman is different. Everyone goes through things differently. So talk to a gynecologist if any specific symptom is bothering you, or if you do need to go on medications, and any other risk factors you have based on what your medical background is. And there's also SSRIs, which are antidepressants, because there's an interplay of serotonin and estrogen in your body. So once estrogen goes down, you'll notice also the serotonin goes down. So you need to make sure that that if you do have vasomotor symptoms, then rather than just hormone replacement therapy, the SSRIs, which are the medications which would help you with the vasomotor symptoms too. To finish off our talk, I just wanted to touch on simple things you can do to take care of your mental health. First thing is talk about your feelings. Anyone, your husband, friends, siblings, anyone you can talk to, or a therapist. Talking about your feelings will help you stay in good mental health and deal with the times when you feel troubled. Keep active. Regular exercise can boost your self-esteem, can help you concentrate, will help you with your sleep, and will make you feel better. Exercise does release endorphins, which I call the happy hormone. And it keeps your brain active, your vital organs healthy, and significant benefit towards improving your mental health. Eat well. Your brain needs a mix of all nutrients to stay healthy. And there's so much research now, and you must have heard about the term epigenetics. You are what you eat. So there's a lot more research to that statement now. What you put in your body, you're going to manifest. All of us do have cancer genes, but they're suppressed. So depending on the kind of environment, kind of food you're exposed to, they could express. Those are the environmental factors which oncologists talk about. So eat live food, stay healthy, avoid processed food, and drink sensibly, which means if you're ever drinking alcohol, limit your alcohol intake, and drink water, which is like the best fluid you can give to your body. 75% of our body is made up of water. 75% of our body is made up of water. So make sure you hydrate, and it helps with all functions in your body. And up to 2 to 3 liters of water in general, but the amount of water you need is half of the amount in pounds. Say if you weigh 150 pounds, so you need 75, and convert that into ounces, 75 ounces of water, which is about, every ounce is about 32 ounces is about a liter. So you need about 2.5 liters or so. So that's how you calculate your water intake. Keep in touch with your friends, family, catching up with someone face to face, because all of us are so used to social media now. Phones are your best friends. So to keep up your mental health, make sure you talk to someone, have friends, someone who you can talk face to face. I know that's not always possible, but try to at least do it often than once every year. So you can always like drop them a note, you can chat, or try to actively call them. I know we get busy with our lives and forget about the rest of the world, but keeping in touch always helps. Ask for help. None of us are superwomen, so we all sometimes get tired or overwhelmed by how we feel, or when things don't go as planned, because women always, I usually call women as having a type A behavior. So they always want things to run in a very specific manner, and when they do not, they get frustrated, they get irritated. So always ask for help. It's okay not to have things go perfectly, and it's okay to be imperfect. And as long as you accept that, you're going to be okay. Take a break. A change of scene or a change of pace is good for mental health. And it could be even just a 5-minute pause. It could be like a 10-minute walk, or a half-hour break from lunch. So anything where you could take a break from your normal routine. Do something you're good at, or just do something you enjoy. You don't have to be good at it. So as long as you enjoy what you're doing, that's all you care about. Just to take a break from your routine and accept who you are. So we're all different. It's much healthier to accept that you're unique than to wish you're more like someone else, or you could do something else. Feeling good about yourself boosts your confidence to learn like new skills, visit new places, make new friends. And good self-esteem helps you cope up with life when life takes a difficult turn. Right, we all go through different things in our lives, and you can't plan it. You just have to deal with things as they come. And then care for others. Friends are really important. We help each other whenever we can. So it's a two-way street, and supporting them uplifts you. And caring for others is often very important. Being kind, having that empathy is really, really important, which is what we should be teaching our kids to be those upright citizens, rather than seeing those scores on the tests, right? So to make sure they're like good human beings who can live in this world and are useful for themselves and others. So take care of yourselves.
It's about training yourself, and you change. And change takes time. Training takes time, as with anything else.
And one last thing I wanted to include was have some kind of mindfulness practice every day. It could be 10 minutes of some any kind of meditation which you've learned, or if it's a guided meditation, just wake up in the morning, use a bathroom, and just sit down before you start your day, maybe about 10 minutes. Anything you want to. If you think you can't, close your eyes and meditate, because some of my patients have concerns about unable to meditate and not even close their eyes for 2 minutes. So open-eyed meditation is an option. You can concentrate on something and meditate, which is just pay attention to what's going on in your body. And mindfulness practice is always, always helpful. And make that a routine in your life. And take care of yourselves. And over to Ramya, and we'll talk more.
And that's really illuminating. I think what would be really helpful, really, for our audience to hear would be, I think, certainly as women, especially when we are trying to balance work, life and our career and children and lots of other things. I mean, it's been an age-old problem, of course, but it's never really been as complex as it is today. So in that sense, being a career woman and getting through the whole pregnancy and childbirth and menopause, it can be quite challenging at the best of times. I suppose in many ways there's also a complication there because I suppose many of us are. It's inbuilt the sense of guilt and responsibility, and it's also about how we balance that and actually say, right, it's okay for us to focus on ourselves. It's okay to. It's important to ensure self care and care for ourselves before we are in a position to be a carer to others, and that's always a complex a balance one has to tread. But tell me, what in your own experience can you give us a couple of examples, maybe, or thoughts or scenarios where you've come across this situation and how women might have dealt with it?
Every day. So there is where you taking care of yourself is not a top of the priority. It's actually they take of yourself so that they can take care of others. The way I put it is, if you're not healthy, if you're not doing okay, there's no way you can take care of them. Right? So you have to pay attention to yourself first, how you're feeling, take care of yourself, and everything will fall in place. Take care of your kids. Like I have some women who like their day starts off at like 4 a.m. Right? They have 3 kids, pack lunches, everything is taken care of before they get to work, and then they come back. Give me 1 second. I somehow sorry. Before they can take care of themselves. So certain scenarios, like some women, one of my patients recently had a miscarriage, right? So she's one of the celebrity who's a TV reporter, and her life was really stressful. I mean, because of their morning news, their life starts at like 3 a.m. before
Yes.
they, and then before the AM news, they have 3 hours of prep. Um, and that's how their life is. I mean, yeah, she gets home in the afternoon and takes care of other stuff, and her sleep cycle was totally off. Like she
Mm.
would sleep maybe in the afternoon from 2 to 10, or then
Yeah.
they would use again. And there's no way your body is going to function with the sleep cycle with that off. So according to Ayurveda and according to the medicine, so most of the interleukins, your growth hormones, are secreted between 10 and 2 a.m.
Yeah.
And according to Ayurveda, sleep should be between 10 and 5 a.m. So which kind of makes sense if you like put both together, and why that sleep is so important. That's how your body functions. I mean, yes, there is a miscarriage, and yes, there's chromosomal abnormalities, which is what we attribute to in the first trimester, but your lifestyle is so important. Like how much water you drinking, what kind of exercise are you doing? All those are, and your stress factors, all those kind of are interwoven into what we do every day. So, and that patient actually quit her reporter job, and now she's doing like a social media job. I recently met her, and she's pregnant again, has a normal pregnancy. So I'm happy for her. And we talked about physical and mental health and how she could balance those. And now she has more time for herself. She's sleeping like she's normally supposed to, and taking care of her health. Um, I think it does make a huge difference your lifestyle, which we call lifestyle as one word, which entails all these things: your sleep and exercise and the food you eat and the mental health, emotional health. So all those play a role into everything which happens in your life.
Absolutely, absolutely. And as you rightly said, sleep is the foundation for most things. Without a good night's sleep, how do you function the following day? It's as basic as that, isn't it? And on the subject of miscarriages, it reminds me of a this wonderful paper I have read, because there's a very complex association between miscarriages and trauma, and how that actually then has an impact on the family in a very complex manner on the mother. And there is a paper that talks about ghosts in the nursery, and it talks about the
the miscarriages that have happened before the baby actually arrives in the nursery, and how these ghosts of traumas past can actually have an impact on the woman as a mother, as a person, as a human, as a wife. And it's how it is really important for us, really, as a society, to recognize and acknowledge that even now it's stigmatized. There is so much trauma, well, there's so much taboo associated with that, that people don't want to talk about it openly. And we really need to be having these conversations, because this it's not anybody's fault, really. Rather, being able to process that in a more productive manner can actually impact the family positively in so many ways, and give a better life to the child that follows. And also about the how a miscarriage is not a definitive end to becoming a mother in every sense. I mean, today, of course, we have so many avenues open. There's the marvels of modern science, but also there's the wonders of adoption, and there's the joy of giving to the community, to other children, and getting that satisfaction. So it's I think it's really helpful for us to kind of start looking at it in a broader context, though it becomes and also to recognize that it's okay and it's important to work through some of these difficulties from a psychological perspective. Just the guilt, the loss, and moving on makes it so important, really, for everybody around to have a healthier life moving forward.
Common question I get as a physician, or any OB would get, is, did I do anything for this to happen? Right? Because that guilt almost kills you inside. And 100% of the times in first trimester, it's never anything you did. Right? It's not because you exercised, or because you are running, or because you did anything else. It's pregnancies are not so fragile that if you run, and if you're like really super, super stressful, even, yes, there is a component of it, but that's not the main reason miscarriages do happen. Right? There is, if we send that the products of conception, what you call, for testing once they miscarry, usually 60 to 70% of the time there are chromosomes which are abnormal. And of course, 30% is unexplained, which there are other factors. But it's always, women always should be reassured that it's not something they actually did for it to happen. Yes, miscarriages do happen. It's always a good idea to talk to the physician about it. And 100% of the times I reassure them to make sure that it's not anything they did for that to happen, and which is usually definitely not.
No, absolutely, absolutely. That's a very important point. One of the other things I come across quite frequently, of course, in my line of work, is the um, the interactions between body image and mental health, and how that, of course, has an impact on one's physical health, because we've seen a surge of eating disorders, and in the context of peer pressures and societal expectations, in a way that we've never seen before. There's been an absolute surge in that, and of course, I think more recently, I mean, it's interesting. It's quite pertinent. I was when I was in the States, I saw in one of the superstores. I actually saw plus-sized dummies there. And it was the first time I'd seen that in a normal superstore, and I saw that, and it was wonderful to see. And these are small things, of course. That, of course, there's more acceptance and acknowledgement as well. But when you're a teenager, or when you're in a high pressured situation, that one can come across in certain professions, it becomes really, really difficult not to conform. What has been your experience of, I mean, of course, I could talk a lot about how it can impact one's mental health, and of course, we've seen as I said, the upsurge in eating disorders. What has been your experience, really, in terms of the repercussions on physical health in the shorter term and in the longer term?
Longer term, let's take the shorter term first. I mean, we do notice a lot of these women, especially when those women get pregnant. If
Mm-hmm.
they have disorders, if there's something going on, they get pregnant, and especially post-pregnancy, these women are at really increased risk for depression. So they are actually their chart is flagged for depression symptoms for pregnancy, because those are the ones which they're more prone to it. And yes, they judge themselves really harshly, and that's not a good thing. Yes, you can reassure them, and yes, you can get them help through therapists, psychiatrists, so they can talk through it. But when we see, like in pregnancy, I see my patients about every month, and then the last 10 weeks, I see them every 2 weeks, and then every week for the month before the baby comes. Right, that's a lot of opportunity to talk to them, interact with them, reassure them, and not have prolonged discussions about this itself unless they're going through something. Because yes, weight is an issue during pregnancy, right? And they depends how much weight they put on. And I had a patient who his BMI was, we have patients BMI 40 and above all the time, but this patient especially stuck in my brain because she's had body image issues, eating disorders before, gets pregnant, and for every even few ounces and half a pound she puts on, she stresses about it. Right. And then it's so important for them to show their weight gain graph during pregnancy, that they need to gain the weight and to make sure for the fetal well-being, and then reassure them. And then I had the opposite. There was another patient who put on about 80 pounds during pregnancy. And also it was very important for me not to stress her a lot about it, and then say, just educate her about the implications after, and then deal with things after, right? And yes, if she puts on so much weight, and there are a lot of implications during pregnancy, third trimester is going to be really miserable for her. But it's always good to take one day at a time, and then support her all through the journey, and say, this is what we're going to work with. And even for them, even the routine things we normally do, like keeping a food journal and go nitty-gritty about like each food, that kind of stresses them out. So you just have to, in general, talk to them about what their food habits are, and rather than just stressing, hey, you put on 10 pounds in 2 weeks, right? So and I think it's a very subtle conversation to make sure that you don't hurt them mentally and emotionally, and at the same time take care of their baby and the patient at the same time.
Absolutely. And it also emphasizes the importance. I mean, we see the overlaps, we see the interplay, and it's also an emphasis really on the importance of um, specialists working together to support as a team, to support the mother and the and the baby. And I don't see there's not many specialities we see it work so well as we do really between obstetrics and gynecology and mental health, I think. Just because you really, I mean, they're so irrevocably intertwined, it's so hard to, really work independently. One has to have an obstetrician has to have a mental health hat on, and a mental health professional who's dealing with women has to have an obstetric or a gynecological hat on. There's no way you can separate the two. And in that context, I think, particularly if we are looking at situations where for whatever reason it's having an impact on the broader family. So if we say we consider that there are particular, just for conversation's sake, there are difficulties for whatever reason with the woman or the young lady in their family, and she's going through a lot, and it's impacting the broader family, of course. Have you, in your experience, worked with families as well, or do you tend to work only with women or children?
So I typically see adolescents and women 21 and above, and I
Mhm.
do see some teen patients come with their parents, and yes, we do work with them for sure. And then for my adult patients, they come with their spouses or family, and it's real, especially for postpartum depression. When they come in for their visits, I always have their partner with them, because they never know the impact of, number one, they do not know that postpartum depression exists, right? And then number two, they do not know, and they are the ones who can pick up the signs even before the patient sometimes, and for the and the family to be supportive. And sometimes they come in with their mothers or mother-in-law sometimes. So it's so important for them to, as a family, to know what the woman is going through. Work with families all the time. And all through the pregnancy, they always come with one of their partners. If the spouse isn't actively involved, yes, they're going to see the husband with them, or their mother sometimes, and then their mother-in-law at the end of the pregnancy if they're helping them with the baby and the postpartum care. And yeah, it's really important for them to be educated about what postpartum depression is, because there's still this stigma about postpartum depression that it does not exist. So when all women go through it routinely, like 80% of women go through postpartum blues, which is the first 2 weeks, right? And then unless they have a supportive family, there's no way that women can get through this. So it's really important. And then I have usually the husband who's there with them 24/7. I have them with the patient so they can understand what's happening.
One of the hardest things a woman and indeed a family has to face is fetal demise. It's hard enough having a miscarriage, but when it progresses and gets to a point where it is an actual loss in every sense, and including the physical sense, the experience is something that really cannot be expressed in words. It's that traumatic. What has been your experiences in this area, and do you have any thoughts to share for some of the some of our women who may have experienced this?
Yes. So any women to go through this, but we do see it from time to time. The longer you have time to bond with the baby, the more the grief and losses. First trimester, yes, women go through a lot. Women grieve, which I really encourage women to. It's normal to grieve. It's normal to go through everything. But once they get to that 5-month mark, 6 months, 7-month term fetal demises, it's very hard to deal with it, and it's heartbreaking. And from the first instance of like telling the patient about the demise, to involving the family, to taking care of her medically after that, and then after she goes home, to see her back. And this is when the postpartum depression really sets in. And so that she has help continually, like at the 2-week mark and the 6-week mark and 3-month mark. So I automatically get all these patients to see the therapist and have a follow-up with the psychiatrist, at least for 6 months to a year. And of course, our psychiatrists are really backed up, and I try to get them appointments as soon as possible. Good thing is we have our psychiatrists right on the floor below us. So I can pick up the phone, call, try to get them in if needed. And the family, educating the family is so important. And also the husband is grieving at the same time. And also to say that men don't show their emotions, and also to help them go through. Yeah, so
it's a very relevant point, actually. It's Men's Health Month, and absolutely, you raise a very relevant point. Men grieve as much as others, as women do, but in a different way. It's very important for us to be mindful of that and support them as well.
Of course, they go through a lot too. So when I'm talking to my patient, I also talk to them for them to see their therapist at the same time. And it helps his wife or whoever he's supporting to make sure that he knows what they're going through, and then help them in a better way, and be there for them. So yes, it is a very heartbreaking thing, but your obstetrician is who you need to talk to initially to get all the help. And I usually even start them off on medications, the SSRIs as needed, and so they could follow up with the psychiatrist to either add on the dose or add an additive medication if needed, for the patients who absolutely need it and they need the treatment right away, so they can really get to the psychiatrist in a timely manner. So I do start them off with medications so they can follow up, and then I follow up with them until I can get them off to a psychiatrist for like a handover to make sure that they still get care in between.
And an added layer of complexity is, of course, if the woman has had a pre-existing mental health condition and is pregnant.
That is huge. Good you brought that up. So I have, yes, of course, we see this all the time. And another aspect of that is undiagnosed mental illness. So if it's diagnosed, at least we know that they're on medications. And I've seen patients sometimes, the doctors take them off the medication before they come in. And they do great the first trimester. And the minute they hit that 16, 17 weeks, and all their symptoms come back and they need to go back on medication. So if they are my long-term patients and I've seen and have been seeing them before, I usually coordinate with the psychiatrist for them to stay on the medication. And then, so that way their transition is normal. And all the women who've been on it, yes, there are risks involved, but their mental health is really, really important. So they need like extra screening, and they need to know what the medication entails. What are they looking at? If it's heart disorders, then they need to have a fetal echo. So they can make appropriate choices, whether to continue this pregnancy, what they want to do. But they need to be on the medications even during the first trimester, so they can have a normal pregnancy, a relatively normal pregnancy. And going back to patients who are undiagnosed mental illness, they are the patients who are really tough because you're making a diagnosis in the context of pregnancy. So where pregnancy itself has so many mood disorders.
Very complicated, absolutely.
And most of those patients sometimes almost never end. The psychiatrists are a little skeptical of starting them on medications right away because there are a lot of medications in pregnancy, at least in the States, which are like D. I don't know how they categorize pregnancy medications there. So here they are category A, B, C, D. D is teratogenic. And most of the medications, psychiatric medications, they come under C and some go under D. So we just have to have that fine line of like making sure. And antidepressants are something which they can go on during pregnancy for sure. So that is a conversation to be had with the patient. And most patients are skeptical to start medications during pregnancy. And it's very difficult to convince them to go through it. And it's going to be something, visit after visit, you talk to them to see how they're doing, to see really if they need the medication. And some medications are okay during breastfeeding. So that is another huge concern. So that is a conversation to be had between you and the patient, and to see if they really need it, depending on what symptoms they're going through, work with the psychiatrist at the same time. So your goal is to make sure that she has a normal pregnancy and a safe pregnancy.
Absolutely. And again, the cultural connotations in any context when it comes to women, I think it's always a complex affair, isn't it? And now that we're in a cosmopolitan era where we coming across kind of cross-cultural populations a lot more than we have ever been before, whether it's for me in London here, for you in the States, and even in the part of India that we come from. It's become all the more important for us to be culturally aware. In terms of our approach, it's particularly relevant within mental health, certainly, because the role of culture, the role of one's approach to, say, a pregnancy or mental illness or any gynecological difficulty it's very different. So it's coming in with that kind of sensitivity and understanding, but at the same time being practical. It's always a difficult balance to it's always a difficult balance, I find.
Yeah, for sure. I mean, especially infertility, what women go through. It is a huge thing women go through. They go through so much, even when they're going through, even if they have to go through IVF, the whole procedure itself, like the mental and emotional part of it, it's so hard to deal with. Recently, I had a patient who had a fetal demise after the IVF and after miscarriages, and that's something it's really unbearable for the women to go through. And the amount of like the help she needs to get back to be stable again, to think of pregnancy, that is going to be a huge journey over the next year or two.
It's a new journey, isn't it? It's a rather heavy topic again, but I think we'd probably be having an incomplete conversation if we didn't touch upon human rights atrocities and, like rape or sexual violence, female genital mutilation, and all of that. Pretty heavy, but it's also the stark reality and the kind of impact it can have on a woman's course of life and her ability to manage her resilience. It's unimaginable.
Um, yeah, I mean, we have some patients with female genital mutilation, and we need to culturally understand like how, what, why. And we have some patients who come in and they do need asylum just because of what they're going to go through if they go back to their country. And yes, we have. I have done that before. Give them letters, and they do come in just to discuss about that.
Yes, yes. I think all of these conversations we're having really highlights one point. It's important that we're having these conversations. It's relevant, and it is something that's really much needed for us to be able to kind of move forward in every sense. One of the commonest difficulties, of course, in South Asian populations that we come across is diabetes now. Diabetes and pregnancy, gestational diabetes, or kind of pre-existing diabetes that gets exacerbated during pregnancy, or any kind of event in a woman's kind of physical health journey. It'd be really helpful to get your thoughts on that, because we certainly see the repercussions of kind of having to deal with somebody with a chronic condition. And sometimes, of course, one of the other things, of course, we come across is that gestational diabetes, of course, can move on into fully fledged type 2 diabetes, can't it? So it's a whole new lifestyle adaptation then in that instance. Yes.
So one of the most important things is in pregnancy is any comorbid conditions along with pregnancy. And it happens all the time. So they're tested for diabetes. Initially, they're screened when they're pregnant. And then again, between 24 to 28 weeks of pregnancy, they're tested again because that's when the hormones are higher, especially the human placental lactogen called the HPL. So that is usually higher during that period. And women who test negative, even in the first trimester, could test positive for gestational diabetes between the 24 to 28 week period. Yes, it's very difficult for women to deal with the diagnosis, number one. And number two, if they have to go on insulin during pregnancy. And the amount of resistance patients have for starting on insulin, which I understand because they have to inject themselves the needle, check their blood sugars 4 times a day. And it's a huge change in their lifestyle for the last few weeks of pregnancy, when they're supposed to really enjoy the pregnancy and not worry about anything else. Right now, they're stressed about blood sugars, they're stressed about every meal, what they eat, and then stressed about how much weight they gain or do not gain just because they've been on this diet, and they see the diabetic nurse every week, and then they see the endocrinologist. And I coordinate with all the other specialties to make sure the patient is doing okay. And the amount of insulin she's taking. So she has to take insulin breakfast, lunch, dinner, and at bedtime, or sometimes just at bedtime. Just even talking to the patient, going through how it affects the baby at birth if they're not doing what they need to do to make sure they take care of those blood sugars. Because we do see increased ICU admits, babies not doing okay, babies' blood sugars dropping down after birth. Increased risk for seizures like epilepsy-like seizures after birth. So we do see all these complications. And when women are educated about it, yes, they're fine going about it and doing what they need to do. And then, of course, the next question is, do I have to do this for life? What does this entail for me for the rest of your life? So yes, about 50% of them 100 resolve totally and do fine. And then the other 50%, or they are at increased risk for diabetes for the rest of their life in about 5 years. So when they come in for the routine exams every year, do their diabetes screening. And right after the pregnancy, after the 6-week mark, there's a diabetes test they do to make sure they're back to normal. And of course, this has an impact on your life for the rest of your life, which is diabetes, increased risk for stroke, heart disease, insulin resistance, obviously, so all those things. And lifestyle is really huge again, right? All the weight they have put on during pregnancy, and it's not easy to get it off right away. So if they put on 50 pounds, I guess you might lose half of it right away. And then the other half, you might keep it on for the rest of your life if you don't work at it. And that again means heart disease and stroke and diabetes and all the comorbid conditions which you expect. So it's difficult. Women go through it during pregnancy, and then after that, it's like a long journey for the rest of the life for them to take care of that.
Absolutely. Now that was wonderful talking to you, Sudeepthi, and it was a very illuminating conversation, I'm sure, for our viewers as well. Certainly enjoyed myself listening to you. It was a chance for me to talk to you as well. And certainly from a professional perspective, which is very refreshing and very different to some of the conversations, but most of the conversations that we have really and have had through the years. So thank you very much for joining me here today. And I'm doing this, of course, on behalf of Cape for Health. As you're all aware, Cape for Health is a comprehensive emotional well-being platform, and we're trying to bring forth to you interesting, stimulating conversations that are hopefully informative as well. I'm afraid we have tried to answer as many questions as we can today, but of course, I'm sure you'll have more, as we usually tend to get lots of questions. Please do email us on the email that you see on the screen, and we will try our best to answer them for you. Many thanks for joining us, and Cape is delighted to be joining you in your journey as we could work together really in terms of resilience and self-worth, and take pride in as women being women and moving forward really. Have a lovely day, everyone. Many thanks to Dr. Sudeepthi Prasad once again, and see you at the next episode of Fireside Conversation. This is me, Ramya, here, Dr. Ramya Mohan, signing off for today. Bye for now.